CICU devices.
Venoarterial Ecmo Basic Clinical Keys. For more insights on ECMO, we invite you to visit our ECMO Guide playlist on the CICU Devices channel. Extracorporeal membrane oxygenation, also known as ECMO by its acronym, is a form of temporary mechanical life support used in critically ill patients with severe cardiac or respiratory failure that is refractory to conventional management. It functions as an external artificial circulation and gas exchange system, allowing time for recovery, decision-making, or transition to more definitive therapies such as durable ventricular assist devices or transplantation. ECMO systems are broadly classified into two main configurations. Veno-venous ECMO, which provides respiratory support in patients with severe but potentially reversible respiratory failure, and Venoarterial Ecmo, which provides both circulatory and respiratory support in patients with severe cardiac failure or circulatory collapse. In this video, we'll focus on the latter, as it is the most commonly used configuration in the cardiovascular intensive care unit, particularly in cardiogenic shock and extracorporeal cardiopulmonary resuscitation. Venoarterial Ecmo is a form of temporary mechanical circulatory support that provides both cardiac and respiratory assistance in patients with severe cardiogenic shock or cardiac arrest when conventional therapies are insufficient. The system functions by draining deoxygenated blood from the venous circulation, passing it through an extracorporeal circuit where gas exchange occurs, and returning oxygenated blood under pressure to the arterial circulation. The primary objective of Venoarterial Ecmo is to maintain systemic perfusion and oxygen delivery while allowing time for myocardial recovery, definitive treatment, transition to a durable mechanical support device, or heart transplantation. Common indications for VA-ECMO in adults include cardiogenic shock from diverse etiologies, as acute myocardial infarction, fulminant myocarditis, acute exacerbation of chronic heart failure, drug intoxication, post-cardiotomy shock with failure to wean from cardiopulmonary bypass, primary graft dysfunction after heart transplantation, refractory ventricular tachycardia, pulmonary embolism with hemodynamic collapse, and in cardiac arrest, used as extracorporeal cardiopulmonary resuscitation. The basic VA-ECMO circuit is composed of several essential components that work together to provide both circulatory and respiratory support. Deoxygenated blood is drained from the patient through a venous drainage cannula and directed into the extracorporeal circuit. A centrifugal pump then generates the blood flow required to circulate blood through the system. The blood then passes through a membrane oxygenator, where gas exchange takes place, allowing oxygen to be added and carbon dioxide to be removed. Gas exchange is regulated by a gas blender, which controls both the fraction of inspired oxygen delivered to the oxygenator and the sweep gas flow rate, thereby adjusting blood oxygenation and carbon dioxide removal. Integrated with the oxygenator, a heat exchanger enables precise regulation of blood temperature, helping maintain normothermia or achieve targeted temperature management when clinically indicated. Once oxygenated and conditioned, the blood is returned to the patient through an arterial return cannula, providing systemic perfusion. Throughout the circuit, pressure monitoring ports and multiple safety sensors continuously assess system performance, facilitating early detection of abnormalities and supporting effective troubleshooting during ECMO therapy. VA-ECMO can be established using two main cannulation strategies: peripheral and central cannulation. Peripheral femoro-femoral cannulation is the most frequently used configuration for VA-ECMO in adults. In this approach, venous blood is drained through a large cannula, inserted into the femoral vein, usually with the tip positioned at the superior vena cava right atrial junction. Oxygenated blood is returned through a cannula placed in the femoral artery. This configuration allows rapid bedside implantation and is commonly used in emergency settings. Because femoral arterial cannulation may compromise distal limb perfusion, insertion of a distal perfusion catheter is often recommended. This small catheter delivers oxygenated blood distal to the arterial cannulation site and helps reduce the risk of lower extremity ischemia. Central VA-ECMO is the other cannulation strategy. In this configuration, venous drainage is obtained directly from the right atrium, while arterial return is delivered into the ascending aorta. Central cannulation is frequently used following cardiac surgery and provides excellent hemodynamic support, although it requires a sternotomy and is associated with specific surgical risks. In addition to the standard femoral and central configurations, several alternative cannulation strategies have been described for VA-ECMO. One of the most important is axillary artery cannulation, which offers several potential advantages over the traditional femoral approach. By avoiding femoral access, it facilitates patient mobilization and early rehabilitation, an increasingly important goal in patients expected to require prolonged mechanical circulatory support. Further hybrid cannulation strategies may be used, depending on the patient's anatomy and the specific clinical goals, allowing the ECMO configuration to be tailored to individual patient needs. Left ventricular distension is a feared hemodynamic complication of VA-ECMO. The retrograde aortic flow generated by the circuit increases left ventricular afterload, which can elevate left ventricular end diastolic pressure, promote aortic and mitral regurgitation, impair coronary blood flow, and cause severe pulmonary edema and potential intracardiac thrombus formation. Multiple strategies to mitigate left ventricular distension have been described. Pharmacologic approaches that include inotropes and arterial vasodilators to enhance forward flow. Mechanical unloading strategies that include intra-aortic balloon pump, percutaneous ventricular assist devices such as Impella, atrial septostomy, transeptal left atrial cannulation, or direct surgical left ventricular apical drainage. A unique phenomenon observed in peripheral VA-ECMO is differential hypoxemia, also known as Harlequin syndrome or north-south syndrome. This occurs when poorly oxygenated blood, due to respiratory failure, ejected by the recovering left ventricle, competes with oxygenated ECMO blood in the aorta. As a result, the upper body and coronary circulation may receive inadequately oxygenated blood, despite apparently satisfactory ECMO support. Anticoagulation is required in most patients on ECMO to reduce the risk of thrombosis within the circuit and oxygenator. Unfractionated heparin remains the most commonly used anticoagulant for this purpose. Monitoring strategies vary among institutions and may include activated clotting time, activated partial thromboplastin time, anti-factor X activity, or viscoelastic testing. Complications remain common during VA-ECMO therapy. Bleeding is one of the most frequent adverse events due to anticoagulation, platelet dysfunction, and acquired coagulopathy. Thrombotic complications may also occur despite anticoagulation and can involve the circuit or the patient. Other ECMO complications include, among others, limb ischemia and vascular injury, hemolysis, infections, and device failure. ECMO is a temporary form of extracorporeal life support that can replace part, or all of the function of the lungs, the heart, or both, while the underlying condition recovers. ECMO does not treat the underlying disease, rather, it provides a bridge that maintains oxygen delivery and systemic perfusion while the underlying condition is addressed. In clinical practice, VA-ECMO is used as a bridge to recovery, decision, transplantation, or longer-term support in selected patients. Finally, weaning from VA-ECMO should be considered when there is evidence of sufficient cardiac recovery and stable end organ function. During weaning trials, ECMO blood flow is gradually reduced while clinicians monitor blood pressure, cardiac output, ventricular function, filling pressures, oxygenation, and laboratory parameters. Decannulation is performed once the patient demonstrates sustained hemodynamic stability without excessive dependence on extracorporeal support. The technique depends on the cannulation strategy used and may involve surgical or percutaneous approaches. In the upcoming videos, we'll take a deeper dive into VA-ECMO, covering topics such as ECMO circuit components, cannulation techniques, nursing care, anticoagulation, complications, weaning, and many other practical aspects of patient management.
If you've enjoyed our video, please press the like button and subscribe to support us so we can continue creating quality content like this.